I'm really happy you all came and to join me in bringing Gorik Ooms here. And before I turn it over to Gorik, I wanted to take a few minutes to talk about implementation science and specifically the CFAR, the Center for AIDS Research, Scientific Working Group for Implementation Science. The CFAR Implementation Science Scientific Working Group started approximately 3 years ago with the intent of improving the speed, efficiency, and quality of translation of scientific evidence on HIV and STI prevention and care into effective health programs working at scale. Now, implementation science is an area that the Department of Global Health has been working on promoting for the last 7 years or so. And a lot of it comes out of really this long gap between the development or the creation of research on what works from efficacy trials, this original research moving towards its implementation at scale to lead to improvements in health. It's estimated that it takes 17 years to turn just 14% of original research to the benefit of patient care. And this is from a clinical environment or clinical perspective. If you think about it from a public health perspective, I think we're falling short both in terms of taking a long time from the generation of evidence, but also to its application at scale to lead to improved health. So it's a bit of a motivation. When we think about how we're defining implementation science here at the department, we're really looking at the incorporation of multiple disciplines to better understand and improve delivery or health systems in delivering these evidence-based interventions. And I want to call out one of the methods here at the bottom, which is policy analysis and advocacy, as an area where we really can't leave off the table. And it's an area where Gorik has been really excelling throughout his career. And if you think about the interventions that are likely to lead to the largest impact in terms of population health, they're probably at the level of policy interventions, probably at changing how business is done through ministries of health or large-scale delivery systems. And this brings me to how I first came to meet Gorik, which was back in 2001 in Mozambique, which at the time was facing an explosion in the AIDS epidemic, really no access to HIV care and treatment except for a handful of pilot projects, and really reticence amongst donors and governments to initiate or take on the AIDS treatment as part of routine practice. Gorik, he was currently at the time representative or country lead for MSF Luxembourg, and he was really at the forefront of advocacy efforts in country, working to implement pilot activities for AIDS care and treatment to demonstrate its feasibility and effectiveness, then also to leverage those experiences into large-scale policy change in Mozambique and also globally. As a result of a lot of these advocacy efforts, Mozambique did take on AIDS care and treatment as part of normative practice, and over the past 15 years, actually the last around decade, has scaled up AIDS treatment with over 700,000 people on highly active antiretroviral therapy at this point in time. And it really demonstrates the role of policy interventions in changing the landscape in which health systems are situated to enable these health systems then to go to scale with highly efficacious interventions. Now to Gorik. Gorik is trained in human rights law. He also has a PhD in medical sciences from the University of Ghent. He has worked across multiple sectors. In the nonprofit sector, on the ground as head of mission for MSF. And at the global level, he was a policy analyst with MSF Belgium and then later executive director for MSF Belgium, and now currently works as executive director for Protection International. He's also worked in academia, previously at the Institute of Tropical Medicine in Antwerp and currently at Heidelberg University Hospital, and has affiliations with Ghent University, where he's part of the International Center for Reproductive Health, and the Georgetown Law and Georgetown University. He brings a wealth of experience in shifting the dialogue on policies and structures that affect health, and it brings a real fresh perspective on the boundaries of implementation research in affecting broad systems-level changes. And I think today we'll have the opportunity to hear more about some of the limitations of implementation science and how we can be reframing the discussion that really enable health and delivery systems to have maximal impact. So please join me in welcoming Gorik.
Thanks for inviting me and thanks for being here. I have to start with a double apology. The first is I arrived yesterday from Belgium where it's now 1:30 in the morning and I'm starting to feel it. I'm doing fine, but I have to look for my English sometimes when I'm getting tired, so forgive me for that. The second is that I'm not really an expert in implementation science, so I was a bit surprised when I got this invitation. I'm a fan of some implementation science, a big fan, but not such a big fan of some other implementation science. And so most of my talk will not be directly about implementation science, but more about the bigger picture and the role that implementation science could have and sometimes has, the positive role, but also sometimes negative or rather conservative. So to avoid you getting lost in my talk, I wanted to give you a brief overview. I want to start with a couple of definitions, the Rationality Project, what I mean with that, and implementation science as I understand it, and then talk about the difficulties of having a dialogue between different disciplines, normative and empirical disciplines. Global health inequity from a right to health perspective. I'm a lawyer. And then the sobering reality. We are, in fact, very far from a world in which the right to health is really fulfilled and respected. And that creates a dilemma for implementation science. And that's what I want to lead to. What do I mean with the Rationality Project? Well, I borrowed this from Jeremy Schiffman, and he borrowed it from someone else, Deborah Stone. The Rationality Project, the common mission of rescuing public policy from the irrationalities and indignities of politics. And you see that happening more and more. It's a trend in global health research, also in public health research. Let's not talk about politics. Let's do everything evidence-based. Yeah? So I don't think that makes a lot of sense. I think public health and global health is about politics. And if you try to take out the politics of that, then you somehow kill it or you make it rather conservative. So I'm not a fan of the Rationality Project. Implementation science, I am a fan in the sense that implementation science goes beyond the purely empirical biomedical sciences and brings in other disciplines, and therefore has the ability to challenge politics. But sometimes implementation science is trying to adapt too much to real-world settings and not challenging those settings. And that's where I think implementation science can be a conservative force. Okay. The difficult dialogue between empirical and normative disciplines. If you want to read more about this, I gave this as a reference. But science is really about truths, about discovering or proving truths. And truths are justified beliefs within a certain framework. And there are many different frameworks. And sometimes, depending on the framework you use, you can look at a situation and come up with very different truths. For example, a lawyer can look at this and say cars coming from the left should give way to cars coming from the right. And that's a truth. It is a truth, perhaps, that cars coming from the left should give way. That's the view, that's a truth for a normative scientist. An empirical scientist will look at this and say, well, they're not doing that. The cars are not giving way. So it seems like a complete contradiction, and it's not. It's just two different frameworks. There's no contradiction between both. One is saying they ought to do something, and the other is saying, well, in fact, they're doing something else. If you don't keep those frameworks separated, you can make them talk to each other, but if you want to have a real dialogue between them, you have to respect them within their own frameworks. And actually, most public health brings together from different frameworks. But for normative scientists, they feel comfortable with it. Empirical scientists often don't feel comfortable with normative statements. And this is the famous guillotine of Hume saying you cannot get an ought from an is. If you look only at what is, you cannot make any normative statements. So there's always something doubtful about normative statements. It's always part of your personal opinion. A typical public health statement or global health statement could be governments ought to provide potable water. Yeah, makes a lot of sense. An article that is trying to argue this will often be purely based on this empirical part. The evidence that shows that the provision of potable water reduces child mortality. And that seems to be sufficient to go from here to here. But actually, you need a normative statement. You need to accept at least that it's the role of the government to do something about child mortality. You need an ought statement to arrive here. In most public health papers, this is completely overlooked. This is taken for granted. Well, there are some people in this country and in other countries who feel that the government does not have a role in improving health. And if you ignore this normative statement, then you run into problems later. And a lot of people will say, don't talk about politics when you talk about healthcare. And actually, a lot of scientists tend to do the same. Let's talk about the evidence. Let's talk about what is proven, but let's not talk about the politics. And you see that in the academic community. For example, this paper about evidence-based policy making, where they see an evolution, a positive evolution, from global health policies based on opinion or whim to global health policies based on evidence. If this is how you're thinking, then all the politics is just opinion or whim. You cannot have a serious discussion, scientific discussion about that. It's all about the evidence. And what I'm trying to say is that without this part, the politics, that part doesn't make any sense. I think global health particularly, but also public health at the national level, is essentially normative. Most of the truths we're trying to prove have a normative content. And even in the common definitions of global health, you will always find these normative statements. So Copland and colleagues saying, improving health and achieving equity in health for all people worldwide. Now, equity, that's very normative. It's very difficult to prove empirically what equity means. Collaborative transnational research and action for promoting health for all. Again, very normative. And at the same time, you see the research behind it moving away from the normative discussion and going more to evidence. Is this problematic? Well, as long as you think that equity is clear, you don't need a lot of discussions about that. You feel intuitively what is equity and what is inequity. But for me, that's not so clear. What does equity really mean? Or what does inequity mean? And this is a definition from WHO. An inequity in health is a systematic and potentially remediable difference in one or more aspects of health across socially, economically, demographically, or geographically defined population groups or subgroups. Is that clear to everyone? Do you all understand what equity means? I mean, remediable. What does that mean? From what perspective? So I wanted to do an exercise with you. So you all live in the US. Imagine that you have a chronic disease and 10% of the population has it. You need a treatment that costs $10,000 per year. You cannot afford it. The government does not subsidize it, so you die. Is that an inequity? Who thinks this is an inequity? Okay, so the others have no opinion, or you don't think this is an equity?
You need some comparison. There's any.
Okay. So let's go to the definition again. Systematic and potentially remediable. So yes, you probably, if you are in this situation, you probably know that people who can afford to pay the 10,000 will have the treatment. People who cannot afford it will not have it. And so you will have a difference in life expectancy between different groups of people. And the question is really, is it remediable? Can the government do something about it? If it is, then it's an inequity. If it's not remediable, then it's not an inequity. I'm now getting confused with my own slides. Okay, so same situation. The only thing I changed is the treatment cost. Now it costs 1 million for a year of treatment. And the government does not subsidize it, and you cannot afford it. Is this still an inequity? Yes? Is there a difference between the previous? Does the amount make a difference whether this is an inequity or not? So if you're saying this is an inequity, you're saying that the government ought to subsidize this treatment. Yeah? So on 100 people, on a population of 100 people, 10 people need it. So you need to pay 10 million to treat 10 people. You probably have to use the income of all the 100 people to pay for this. This is in itself not remediable because it's too expensive.
There are trade-offs.
Sorry?
There are trade-offs.
There are trade-offs. And to make it more complex, what if the treatment costs 1 million, but the government could do something else and subsidize it? It could issue a compulsory license and bring the price down to 10,000 again. And then again, it's remediable. Yeah. So your judgment on what an inequity is really depends on your opinion on what the government ought to do. It's all about politics, inevitably. You cannot define equity or inequity without thinking about politics and the role of society and the role of government. Now imagine this in Mozambique. Exactly the same situation as the last one in the US. The difference is that Mozambique is a far poorer country. Is this an inequity? Who thinks this is still an inequity? Okay? So you're saying it's remediable. How? At 10,000, it's still unaffordable for the government of Mozambique. Let's assume that you can't bring the price lower than that. If you're then saying this is an inequity, then the assumption behind it is that not only the government ought to do something about it, but also the international community. And that's actually the dilemma we had in Mozambique in 2000, 2001. We're talking about different figures, 10,000 for a year of AIDS treatment, and we knew we could bring it down to 350. But still 350 was too much for the budget of the Ministry of Health. So taking a position, this is an inequity, this is unacceptable, meant having an assumption, we think the global community, the international community, should pay for this. And that's where it gets more complex. I think most people would agree that at the national level, governments are responsible for the health of people. At the international level, is the international community responsible for the health of the entire humanity? That's a more tricky question. I think it is, but a lot of people don't think it is. Some people say, yeah, perhaps we should do this if it's an infectious disease. And then it's not about equity anymore. Then it's about self-interest. Let's control TB in other parts of the world because we're scared of TB coming to our countries. So you have different normative assumptions about why the international community should finance healthcare in lower income countries. And depending on your assumption, you will have a different opinion on what the priority should be. So, concrete example, a paper from Danny and Emmanuel saying that, so quite normative here, the allocation of international health aid should be guided by 3 fundamental principles: to save most lives, young lives in particular, to do so using finite resources most effectively. And based on these normative assumptions, they said we should spend less on AIDS treatment and more on other health issues. Now, if your normative assumption is that the international community should give international health aid because health is a human right, then you would not come to this statement. Then you would probably come to a statement, we should increase the budget at the national level, but also at the international level. We should not save money on AIDS treatment to do other things. We should just increase the overall budget for global health, and then we can do both. If international health aid is based on enlightened self-interest, control of infectious diseases, then yeah, probably you should continue to finance AIDS treatment and ignore other interventions that are perhaps more efficient, but that are not related to infectious disease. And if international health aid is based on charity, then the donor is free to decide what the priorities of the donors are, and then perhaps particular sensitivities of the constituencies will influence the priority setting. And then, so depending on which normative assumption you use for global health, you can come up with different conclusions. Okay, so now I want to go to the right to health perspective. Health as a human right, for the same reason, because, well, it's perhaps because I'm a lawyer, but for me, the whole equity, inequity definition are not useful enough. It doesn't help me enough to decide this is what the international community should do, this is what the international community should not do. And therefore, I look at human rights because equity, the definition we had before was a definition of inequity. Here it's equity, principle of being fair to all persons with reference to a defined and recognized set of values. What kind of recognized set of values we have? Well, you can look at the Millennium Development Goals, now the Sustainable Development Goals, but they're all just declarations. In law, in international law, a treaty has a higher authority than a declaration. So if we look at the law, what does it say? First of all, which international law should we look at? We have the Universal Declaration of Human Rights, which is not a treaty, it's a declaration. Yeah? So it doesn't really have the same value. And then it got separated in 2 international covenants, one on civil and political rights and the other on economic, social, and cultural rights. 2 different treaties, And some countries have only ratified this one and not that one. For example, the USA. USA recognizes civil and political human rights, not economic, social, and cultural rights. And I want to explain you a little bit. I mean, this is lawyer talk, but that's necessary to help you understand what the obligations are. Is this relevant? First, a caveat. Yes, I agree with John Tobin when he says that looking at the right to health in international law comes with a challenge, that is that some people are extremely enthusiastic and optimistic about it, to a point that it doesn't make sense anymore because it's not corresponding with reality. That's the lawyer saying the cars should give way to the other cars, but nobody is doing that. And the deeply pessimistic views, the people who ignore international law completely because they say there is no way to go to a court and to make states behave as they should. I'm kind of in between. I am an optimist by choice, not by conviction. I know that international law is weak, or that certain parts of international law are weak, but I still think it's the best we have. I find it more useful than the equity. Definition of human rights, actually definition of basic rights, and that's not a coincidence because this is a US scholar and Henry Shue wanted to move away from the whole semantic discussion about what human rights really are and whether it's both the civil, political, and the economic and social. So he said, let's talk about basic rights, about fundamental rights. And the first definition there is quite easy to understand, I think. Basic rights are the morality of the depths. They specify the line beneath which no one is to be allowed to sink. Make sense? It's actually not much clearer than equity. But now, and then there's this definition. I think this is the kind of language that only lawyers can come up with. They are the rational basis for justified demands, the denial of which no self-respecting person can reasonably be expected to accept. Yeah? Okay, you need to read this a couple of times. Actually, what Shue does here is he organizes a kind of dialogue between the individual and society. To know what human rights are, you have to think from the perspective of the individual, what are my demands to the community, to society, of which it cannot reasonably expect me to give them up. And the society that kind of responds, what are the demands of the individual of which we cannot reasonably expect him or her to give them up. And if you get answers to this question, you do a kind of mental ping pong, and you can say, for example, torture. Is it a reasonable demand of the individual to say, I expect my community never to torture me? Is that reasonable?
Yes.
Yeah? And is it a reasonable reply of the community to say, we should not expect any individual to give up their right not to be tortured? Yeah? What about the 1 million treatment in this dialogue? Is that a human right? Is it reasonable for an individual to say, listen, I need this treatment, otherwise I'm going to die. And therefore, my community should not expect from me to give up my claim to that very expensive treatment. It depends on many issues. But if your average income is around 50,000, then the reply of the community will be, hey, let's get serious. If we want to give this treatment to everyone who needs it, 10% of the population, that means we're going to spend everything we earn on this treatment. Yes? Yes, that's the fundamental question here. If you're saying you can't put a price on life, then you say, whatever the costs of the treatment I need, society should provide it to me, even if society goes bankrupt because of that.
Even if I'm 90 years old.
Even if I'm 90 years old. And so that's where Shu says, no, it's actually not so clear. You have to have this dialogue. And sometimes it's reasonable that society says, no, sorry, this is too expensive. You should not expect us as a society to sell our houses and to give everything away to keep you alive on those medicines. Yeah? And that's somehow a reflection of this remediable in the definition of equity. If the demands on society are such that it's not really reasonable anymore, then the problem is not remediable. Now, for me, the big question here is, who's the society? Who decides? Those questions are very much related. Because at the national level, as long as you stay within the national level, and assuming that you're in a somewhat democratic society, you can say, we agree on the principle, but at the end of the day, Parliament, Congress will have to decide on how far we go. And in some countries, they do it very explicitly. In some countries, they know exactly how much it can cost. For example, in the UK, you have NICE, this institute that is making this calculation. Parliament gives them a budget, says the budget for the national health system is this. Now figure out how many lives you can save with this. Maximize the utility of this budget. And that gives them a threshold of about 40,000, 45,000 per life year. Any treatment that is below 45,000, NICE will say, yes, government should subsidize it. Every treatment that is more expensive than that, NICE will say, nope, government should not subsidize it. This is not a reasonable demand anymore. Well, not within the budget that is set by Parliament. So who decides in the end? At the national level, normally your political system. But in the example that we've seen of Mozambique, we went beyond the national level. We said at a certain moment, this is not just a decision or responsibility of the government of Mozambique. This is not just a responsibility of the society of Mozambique. This is a responsibility of humanity. Now then, which parliament will decide how far this should go? The World Health Organization? Not so clear, unfortunately. So if you do this ping-pong, this mental ping-pong a couple of times, you come up with the essential do's and don'ts of organized societies, of polities. Don't torture people. That's an easy one to understand. Don't enslave people. Don't punish people for expressing their thoughts. And some do's. What societies should positively do for individuals to ensure their conditions for survival, subsistence, and dignity. Now, this is, in a sense, the reason why this Universal Declaration has been divided in two different international covenants. The don'ts are better known among lawyers as the freedoms, also called negative rights. It's a bit misleading. It's not the right in itself that is negative. We call them negative rights because the corresponding obligation of society is to do nothing or to not do something. Do not torture people. Do not put people in jail because they express their opinions. No? The entitlements are linked to these essential do's. what society should do for people. And they're called positive rights. Rights you have because society should do something for you in certain circumstances. And these are the economic, social, and cultural human rights, the treaty that the US did not ratify. Why did we put them in two different treaties? Well, the first reason is that some countries didn't want to recognize the entitlements, only the freedoms, but also that the responsibility of the governments is quite different. And you see that when you compare the two different treaties, specifically in Article 2.1 at the beginning, for civil and political rights, each state party to the present covenant undertakes to respect and to ensure to all individuals within its territory and subject to its jurisdiction all the rights in that covenant. In the Covenant on Economic, Social, and Cultural Rights, you have similar language, but with some differences. In green, undertakes to take steps to the maximum of its available resources. Why do we have this here and not here? Why is there a different formulation for this? Yes. So this is supposed to cost nothing, which is a bit misleading. I mean, you need a justice system and a police force, etc. But the idea here is that the only thing we're asking governments to do is not to interfere with people's lives, not torture people, not put people in prison for expressing their thoughts. And therefore, even the poorest country in the world can achieve this without external help. At least that's the idea. Here, there's a recognition that realizing these rights costs money, and therefore not all countries can do the same. And what the government of Mozambique can do in terms of realizing the right to health is quite different than what the government of the US can do, because of a difference in budget. So the right in principle is the same, but the corresponding obligation of governments is to take steps to the maximum of its available resources. And the maximum available resources in the US will be a lot more than the maximum available resources in Mozambique. Now, when they wrote this, they realized that there was something problematic with this, that you had human rights, but actually the meaning of that human right depends a lot on the wealth of the country you live in. And so in the last minute, they included this blue part, individually and through international assistance and cooperation. Again, for the same reason, it costs money. Some countries cannot afford it. And then other countries have to help. But they didn't really agree on how far to go in this. And so, depending on your interpretation, some people look at this and they say, all states should take steps using maximum available resources to realize the right to health for all human beings without any distinction of any kind. Not even the distinction whether people live in their own territory or somewhere else. Concretely, this would mean that you reduce the current budget for health in the US from, what is it, $10,000 per person per year now? To $500. That's the global average. And with that amount of money, you can increase the budget in Mozambique from $10 to $500, and everywhere else in the world. Now that seems a little bit exaggerated. But some people think this is what a human right really means. The corresponding obligation falls on humanity. The lawyer in me says that the formulation of the text says it's state responsibility with some responsibility of international assistance. The other extreme interpretation is that all states should take steps using maximum available resources to realize the right to health for their citizens first, and then perhaps use the leftovers for citizens of other states. Now, the problem with this is that there won't be any leftovers, because you never achieve the highest attainable standard of health. As soon as you get there, pharmaceutical companies will come with a new medicine that is even more expensive and that can prolong lives with another 6 months or 1 year. So you never get there. If you have this opinion or this interpretation, then there is no responsibility of international systems. So, in between both, you have an interpretation, and this would lead us too far to go into details, but an interpretation based on the idea that for every human right there is a core content. There is a minimum essential level below which the human right doesn't make sense anymore. And if you can put a price on that, for example, for universal health coverage, if you can say, okay, with a budget of $86 per person per year, you can provide really the basics. Then the national responsibility would be to spend, for example, 5% of GDP on universal health coverage, meaning that Burundi is somewhere here, and Mozambique somewhere here, and then Kenya somewhere here. And then the responsibility of the international community would be to fill the gap between those. And if you want to know more about that, there's a report from WHO on what universal health coverage would really mean if you anchor it in the right to health and take this international dimension into account. Okay, so that's what the right to health demands. Not the same level of healthcare everywhere in the world, but at least a basic minimum for everyone with a shared responsibility. Now the sobering reality. Per capita government expenditure on health at an average exchange rate in low-income countries, $13 in 2012. So we're very far from that $86. We're very far from being in a position to provide basic healthcare to everyone. And the responsibility is both at the national level, where countries are still very far from the 5%. This is somewhat misleading because this is total expenditure on health, and only 38% of that is government expenditure. And it's also not enough international assistance. Now, if you see this as a human rights violation, and it takes a bit of thinking, but actually, in my opinion, this is a huge human rights violation on a massive scale permanently, that creates a dilemma for implementation science. If you want to do research in a context where the budget is only $10 per person per year, and adjust to that reality, where it should be at least $80 per person per year, how do you deal with that? Sometimes I think it's like implementation science for slavery. How do you do scientific research on how to improve slavery? Huh? Seriously, I found it a dilemma working in countries like Mozambique. The whole system is unacceptable, and still you're working in it, and you're trying to achieve minimal progress, but realistic progress in that. So one assumption, if you're confronted with that situation, and actually a lot of global health scholars do that, is just to assume that realistically the resource envelope for a given country of the previous year will be more or less the same for next year. If it was $10 last year, it will be $10 next year. And so let's see how we can optimalize those $10. Logically, that's a flaw. That's an appeal to tradition. That's just assuming because things were like that in the past, they will be like that in the future. The other way of dealing with this dilemma is to say, no, let's assume that next year or the year after, finally states will live up to their obligations. If you do that in Mozambique and you start doing research assuming that the budget of next year will be $86, then you will come up with a lot of grand ideas that are completely unrealistic. And that's another kind of logical fallacy, an appeal to fate. Okay, now implementation science. Finally, the dilemma, real-world settings. The problem with real-world settings, for me, is that it creates a tendency of appeal to tradition. It's trying to find solutions within the current circumstances, even if those circumstances are completely unjust. It's like trying to reduce the working hours during slavery instead of challenging slavery. The advantage of implementation science is that it can include a range of theory and methods. And so it can include politics. It can include other options, other political options, and therefore it can challenge the status quo. But there is a risk of going into an appeal to fate. And you see that there are a lot of projects, and I think MSF, in comparison to what High did, was going a bit too far in that direction at a certain moment. Saying, let's assume that the number of doctors is unlimited, and if needed, we'll bring them in from Belgium or from other parts of the world. Let's assume that costs are not a problem. See how good we can do. See how nice the results are. But then you build a project that has great results, but that cannot be taken over by the government or cannot be scaled up by the government. So you're still in this dilemma. And so I think one of the greatest examples of implementation science challenging the political status quo was in AIDS treatment, was the kind of projects we did in Mozambique and in other countries. Because remember, you were talking about 2001. In 2001, it was not accepted yet as a normative truth that the international community should pay for AIDS treatment in low-income countries. That was still heavily contested. And there weren't that many politicians who said openly, sorry, we have no responsibility for the health of people in other countries. They used excuses. And one of the excuses was, well, in Africa, people don't have watches, and AIDS treatment, you have to take a pill in the morning and at noon and in the afternoon, and if you don't have a watch, then that treatment is not going to work. So there were many myths about that. And I think the projects that we did in Mozambique with a very low budget actually showed, yes, even in this low-income countries, it is possible. You can do it. And by showing this in pilot projects, we challenged the political status quo. And we increased pressure on the Global Fund and on PEPFAR and on governments to make sure that enough money was available to provide AIDS treatment everywhere in the world. Another example of which I was also involved indirectly, MSF did a lot of this, and where I think we were perhaps a bit too conservative and confirmed the status quo, was in the whole task shifting discussion. And at the beginning, it was shifting from doctors to nurses, and there I think it made a lot of sense. But at a certain point, we started saying people can self-treat. You initiate the treatment, and then you create patient groups. And the results were actually not always so convincing. And I felt that perhaps we should have challenged the reasons why there were so few health workers in these countries. There were political reasons for that. There were conditions by the IMF and the World Bank that made it very difficult for the government of Mozambique to increase the number of nurses. And this is the kind of implementation science where I'm saying, well, this is tricky. This is perhaps confirming a situation that is in itself unacceptable. But I think it is, in the end, like walking a tightrope. If you go too much in the direction of the normative side, this is how things should be, then you will come up with projects that cannot be copied, that cannot be rolled out. If you lean too much to the other side, then yeah, you won't really challenge the political situation. You won't challenge the status quo. And that's where I'll end.